Welcome guys into this another discussion in which we will discuss some of the MCQs on pulmonary edema. So coming to the first question, it says a 36-year-old male presented with sudden onset breathlessness, and there is along with drop in SpO2 level associated with frank, frothy, pinkish sputum in emergency. All medical records were not available at the time of arrival. Initial provisional diagnosis of pulmonary edema was made. Now, which of the following investigation is not used to distinguish cardiogenic and non-cardiogenic causes of pulmonary edema? So this is a typical presentation of pulmonary edema. Pulmonary edema is usually acute in presentation. It is usually acute in presentation and presents with severe shortness of breath, sometimes associated with cough, with pink frothy sputum, profuse sweating. Sometimes it can be associated with cyanosis, anxiety, restlessness also. So this is the typical presentation, and people woke up at night. They complain of waking up at night due to breathlessness, but breathlessness settled down when they woke up. Then, because due to the position change from the supine to sitting position, breathlessness settles down. This is the usual typical presentation of any pulmonary edema cases. Now, once you know that this is a pulmonary edema, next step involves to distinguish whether this is a cardiogenic cause or non-cardiogenic cause. Alright, non-cardiogenic causes. Now, it can be differentiated based on the history, physical examination, which can give some clues then to investigation or the radiological investigations or laboratory-based investigation. Now, cardiogenic causes can be due to the MI, due to heart failure. Alright, it can be volume overload associated causes. Alright. Now, non-cardiogenic again, that is pulmonary related, or which can be direct injury to the lung or indirect injury to the lung. Direct injury can be due to the pneumonia, can be due to aspiration, can be due to anything like ARDS related or perfusion related, pulmonary contusion associated, pulmonary infarct associated. Indirect injury can be due to sepsis or transfusion related acute lung injury, due to cardiopulmonary bypass, due to acute pancreatitis associated SIRS. Indirect injury can be there. So this is the broad distribution, and we need to check what are the investigation can be done or not done to distinguish between cardiogenic and non-cardiogenic causes of the pulmonary edema. Now again, so here if we differentiate pulmonary edema causes, it can be cardiogenic and non-cardiogenic. Cardiogenic can be due to acute MI following cardiac arrest, myocarditis. It can be due to stress-induced cardiomyopathy, or severe valvular heart disease. Alright. Now this non-cardiogenic is again broadly divided into two groups, which is due to the direct lung injury, group, or indirect lung injury group. So direct lung injury, for example, there is direct effect on the lung parenchyma, that is in case of pneumonia, aspiration, inhalational dust exposure, or pulmonary infarct. These are all the causes of the direct lung injury. Indirect lung injury can be due to the sepsis factor, see transmission related, then acute pancreatitis associated. Right? These are all causes. Now, how to differentiate? We can differentiate based on history, based on lab parameters, based on radiological investigation. History that essentially gives clue regarding this cardiogenic and non-cardiogenic variety is like that. In cardiogenic, for example, in clinical examination, you will get signs of raised GBP, you will get peripheral edema, peripheral pitting variety of edema. On auscultation, you will get S3 gallop sound or rales and bronchi bilateral associated rales. And in cardiogenic variety, this rales or bronchi or wheeze, whichever you say, will be more concentrated in the central region. Whereas in non-cardiogenic, it is more in the peripheral region. GBP will not be so much raised in case of non-cardiogenic, and peripheral edema usually late onset compared to the cardiogenic. Alright, and cardiogenic early onset peripheral edema is seen. Now, that thing only that I have said. So, the evidence of increased intracardiac pressure, that is S3 gallop, elevated GBP, peripheral edema seen in the cardiogenic one, and rales and wheeze on auscultation of the chest. Whereas these are normal on early stages in case of non-cardiogenic. This rales and wheeze on auscultation of the chest is more in the central region or evenly distributed in cardiogenic. Whereas in non-cardiogenic, it is patchy, more in the peripheral than the central one. Now, based on radiograph, chest radiograph also we can differentiate. Now, coming to this causes again, direct lung injury causes and the indirect lung injury causes. Direct is pneumonia, aspiration, pulmonary contusion, fat emboli, one of the important cause. Fat emboli, very important cause, and sepsis, cardiopulmonary bypass, acute pancreatitis, transfusion related blood product causes the indirect lung injury. Now, coming to the radiological distribution, so the thing that you need to check in the chest X-ray to differentiate between the cardiogenic and non-cardiogenic is first look at the heart size. Obviously, it will be normal or greater than normal in case of cardiogenic one. Secondly, look at the width of the vascular pedicle. Width of the vascular pedicle will be normal or more on the greater higher side in case of the cardiogenic. Vascular distribution, vessel distribution usually remains normal or balanced in all of these cases. Edema is usually seen in cardiogenic cases. That is, edema means distribution of edema. That cardiogenic cases is central region or evenly distributed, whereas patchy or peripheral in the non-cardiogenic one. The proliferation will be seen in cardiogenic variety, but less likely in non-cardiogenic variety. There are special signs like peribronchial cuffing or ear bronchogram. Ear bronchogram will be more in non-cardiogenic one, whereas peribronchial cuffing in cardiogenic one. So, what are the parameters we need to look into? We need to look into firstly the heart size. Second, vascular pedicle. You can look, okay, vascular pedicle. Then edema. Where is the edema situated? Then edema. Then proliferation present or not, or special sign. Proliferation present or not. Then look for the special sign. In special sign, what are the things that we need to look? We need to look for the ear bronchogram, or peribronchial cuffing. Now let's look into the images. In this image, what is seen? Look clearly, cardiac size is more compared to the first image. In the first image, it is more compared to the second image. Right? So cardiac size is more here. Then width of the vascular pedicle. This is the vascular pedicle part, and obviously vascular pedicle width has increased in the first one. Edema. If you look at the edema part, compare the edema. Look, edema is more or less centrally distributed here, whereas here it is like patchy and full distributed, and you can get in whole of the lung fields edema. Alright, so edema gone. Then next, proliferation is not observable in both of the cases. So, but there is flattening of the lung border, lower of the lung border, diaphragm border is flattened here in this X-ray. Now let's look into the special signs. What is special sign? We have to look for air bronchogram and peribronchial cupping. Now, what is peribronchial cupping? Peribronchial cupping is the haziness or increased density around the wall of a bronchus or large bronchus. Alright. So, if you look, we will go into the better image. This is actually peribronchial cupping. You can see a haziness or increased density sign around this bronchial. So, like this is bronchial. So, around this there is increased haziness, which is peribronchial cupping. It is a sign of, basically of sign of cardiogenic edema, cardiogenic pulmonary edema. Whereas air bronchogram occurs when there is pulmonary infiltrates or fluid accumulation in the tissue immediate next to the bronchi. So, if this is a bronchi and there is fluid accumulation in the tissue immediate next to it, it will result into increased density in the tissue, which manifests as opacification. Alright, and there is darkening in the bronchus. So here look, there is darkening and immediate there is increased opacity. So this one, second one is of most likely non-cardiogenic. Again, it is not specific variety, non-cardiogenic, and first one is cardiogenic pulmonary edema. So again, let's look in this diagram. Okay, this is a proper diagram. You can see there is a bronchus, and there is, beside this bronchus there is haziness. Okay, so this haziness represents the extravasated water surrounding the bronchus, which is nothing but peribronchial cupping. Alright, and in this diagram you can see there is a dark line, beside which there is opacification. So this dark line is the bronchus, and immediate to the tissue surrounding the bronchus there is edema infiltration, which is seen in case of mainly consolidation or in case of the non-cardiogenic variety of pulmonary edema. Now, beside this can be also seen in non-obstructive atelectasis, pulmonary infarct, normal expiratory phases also. So, air bronchogram sign should be taken lightly. Alright, it is not so much specific for non-cardiogenic pulmonary edema to say, right? It can be seen in consolidation. Alright, it can be seen in consolidation. Okay. So these are the causes again, the cardiogenic causes and the non-cardiogenic causes. Cardiogenic due to increased hydrostatic pressure as in heart failure, decreased oncotic or hydrostatic pressure, or it can be due to volume overload. Non-cardiogenic can be infection related as in case of sepsis, trauma, inflammation, aspiration related. It can be due to the pancreatitis, it can be due to toxin mediated metabolic causes, and it can be also due to ventilator induced lung injury. Basically, you should divide it non-cardiogenic into direct lung injury and indirect lung injury variety. Okay. Now, ntProBNP usually remains higher with the cardiogenic or heart failure associated parts. Okay. So, if we look into the question once again, and before that, the other thing that we can use. So, this is 2D equal to look for the pleural lines, pleural lung ultrasound. And in lung ultrasound, we can check for the acute variety where this cardiogenic edema will suggest to go white line, thin, even appearance of pleural lines, whereas if there will be thickening In case of ARDS, non-cardiogenic one, normal lung sliding will be present, whereas there will be inhomogeneous appearance of lung sliding, as in this case, inhomogeneous episodes of lung sliding. There can be consolidation seen, air bronchogram seen, and lung pulse seen, whereas homogeneous appearance of lung tissue and transudate appearance of the prolongation can be seen. Okay. So now, even after all those tests, if for the clinical examination is not suggestive of so much of what is the main cause or etiology behind this cardiogenic edema, what can be tried is pulmonary arterial catheterization. This is nothing but Swan's catheter. So when edema is refractory treatment, what we need is accompanied by complication like hypotension, pulmonary arterial catheter can be used to find the etiology. Like what does it do? Pulmonary arterial catheter, it goes till way up to from the right atrium to up to till to the pulmonary artery, and balloon is inflated, which does the tracing bed. Now it allows the measurement of pulmonary capillary wedge pressure and helps to differentiate between the high pressure and the normal pressure cause of pulmonary edema. So high pressure one is seen in cardiogenic variety and normal pressure in pulmonary non-cardiogenic variety. So what is the normal? Normal is less than 18 millimeter mercury. So if the pressure is more than 18 millimeter of mercury, it is suggestive of cardiogenic pulmonary edema. So coming back to the question once again, so what is the question says? Question says us that a 36-year-old male came that time, okay, to presented with typical presentation of drop in SpO2, breathlessness, and frothy pinkish sputum, which are suggestive of pulmonary edema, and we need to do the investigation to find the causes. So which investigation will do? We can go for echocardiography. Yes, we can go for echocardiography. Why? Because some of the causes of cardiogenic edema like MI or valvular heart disease, echo will give a prompt input, like whether there is any regional wall motion abnormality present or not. So echocardiography is obviously useful. ntProBNP, yes. ProBNP is released due to the stress by ventricular myocyte. When there is stress, it is released from myocyte, which results into natriuresis mode. Okay, so ntProBNP can be used. PCWP, that is pulmonary capillary wedge pressure, we have just seen. Based on this, less than 18 is suggestive of non-cardiogenic and more than 18 is suggestive of cardiogenic. Even it is the most specific test to identify which of the variety of edema was there. Serial ABG analysis, no. Serial ABG analysis has no value in detecting of the variety. Alright. Okay. So coming to the next question. Okay. What does this question says? This question says about a 68-year-old gentleman came to your OPD with complaint of breathing difficulty on exertion and swelling of legs since 6 months. Okay. But is worsened since last 2 months, and there is history of frothy sputum. On auscultation, you find rales in bilateral chest, more concentrated in interscapular region. Okay. So from this history only, you can see if it is a pulmonary edema and there is peripheral edema history, breathing variety, there is breathlessness difficulty for this sputum, bilateral chest auscultation, there was rales, and which is more in the interscapular region, that is central distribution. So obviously, in such cases, provisional diagnosis will be what is given here, that is the cardiogenic diagnosis will be cardiogenic pulmonary edema. Alright, cardiogenic pulmonary edema. Now you ordered a test ntProBNP and which came out to be 245. Okay. So which of the following is false regarding the test? Okay, very much interesting. Now ntProBNP can be falsely high, falsely low in a lot of the cases, and it should be always assessed and compared with what is the other values. Alright, what is the other values and what is the clinical history. If clinical history is strongly suggestive, then only it should be given more focus. So if it is less than 300, heart failure is always unlikely. Alright, less than 300, heart failure is always unlikely. If it is more than 10,000, eyes closed, most likely this is heart failure, and you may need to admit the patient. Now what happens in the middle part? Middle part is lot of gray zone there. Okay, so there is age specificity, like if age is less than 50 years, 50 to 75 years, and more than 75 years. In less than 50 years, what you need is less than 50 years, more than 450 plus history and physical examination is suggestive. Look, history and physical examination is always mandatory to guide you in ntProBNP. Single reading of ntProBNP has no value, but it should be always guided with history. So less than 50 years, more than 450, alright. Between 50 to 75 years, more than 900, and more than 75 years, it's more than 1800. That's the value that you should keep in mind. And more than 10,000 at any age group is high likely of heart failure. Now, what are the other things that is mentioned here? So this level can be falsely high in obesity. Okay. It helps in assessing disease severity prognosis. Okay. It can be decreased in cardiac component. It can be used as guide to titrate the dose of medication. Obviously, from this classification here, you know, the second statement, it helps in assessing disease severity of prognosis is sure. Because if there is very high, like 10,000 or 12,000 coming at the OPD basis, we will directly admit the patient because the patient needs treatment and patient will collapse at any moment. Alright, but therefore it is helping you to assess the disease severity. But we need to check what are the other statements, how much truth is there. To know this, we have to know where from this ntProBNP is coming. It is released from cardiac myocyte of ventricles and releases ntProBNP in response to stretching caused by the increased pulling of the blood volume. Circulatory blood volume, when it pulls, stays in the heart. There is stretching of the ventricular myocyte, resulting into release of ntProBNP. Alright. Now, okay. So this is the thing that I was talking about. So ProBNP, when there is myocyte stretch or myocyte ischemia, it results, and obviously source is ventricles, from which it is released, and it results into natriuresis. Alright, the pressure effect, to relieve the pressure effect. Now, when does it will get falsely high or falsely low? Coming to this chart, look. So, as the source is ventricular myocyte, if there is any dysfunction in left ventricle, a small stretch can result into elevated level of natriuretic peptide. Previous heart failure weakens the ventricular myocyte, resulting into more propensity to of increased NP level in small stretch level, advanced stretch obviously, and renal dysfunction. And acute coronary syndrome, all of this event can cause elevated NP level. Alright. Then high output stage like sepsis, cirrhosis or hyperthyroidism, there can be high level of ntProBNP. Now lower than expected. When it can be lower than expected? When the stretch on the myocyte is masked by something else. For example, the person is so much obese, compression so much obese, there is more of the ventricular myocyte, and so stretch is not so much affected on the myocyte ventricles. Similarly, in case of cardiac tamponade and pericardial constriction, pressure is evenly distributed and there is no extra pressure during when there is pulling of the blood. Alright. So in such cases, it will be level lower than expected. It will be raised, obviously raised, but level lower than expected. Now, as the source is left ventricle is the source. So, if there is heart failure upstream from the left ventricle, that is, source of the heart failure is due to mitral regurgitation. So, obviously, left ventricular myocyte will not be involved. Therefore, source upstream from left ventricle, as in case of acute mitral regurgitation or mitral stenosis, ntProBNP level will be low. Alright. Okay. Now, what are the options? Let's look again. So we know from here, already we know the answer part actually, like it can be decreased in cardiac component. True, it can be decreased in cardiac component. This level can be falsely high. No, it remains falsely low in case of obesity. So obviously option A is wrong. But regarding the option D, it can be used as a guide to titrate the dose of medication. Different school of thought has different belief regarding this. Alright. So what are the studies that say? Studies that was published in 2005, and it is taken like whether BNP guided therapy would provide outcomes superior to empirical therapy. That was done, and in this theory it is shown that in BNP guided therapy, the group assigned to N-terminal BNP guided treatment received higher dose of ACE inhibitor, diuretic and spironolactone, and heart failure event in the terminal BNP guided were fewer than those of the symptom guided after 10 months of follow-up. Okay, so who received BNP guided therapy has less incidence of heart failure compared to the non-BNP guided therapy. So based on the present study and the data we had, obviously BNP guided therapy is much better. Now, same study also said that more trials are required for this, as proper randomized trial are not available. Obviously, this is a controversial topic. Okay, so that's all. Now, what is the treatment part? Treatment part can be easily remembered like positioning. We need to position the patient, right? Because when there is patient lies in the supine position, there is fluid accumulation in the base of the lung and resulting into more respiratory distress. So supine positioning or head end elevation to 40 to 45 degrees is the primary thing. As well as you can try for positive pressure ventilation. Some oxygenation might help the patient. Then obviously diuretic therapy to take away the fluid from the lungs so that the patient symptom relieves, and as well as nitroglycerin sometimes do help. Okay. And this is acute management. Main and the therapy should be aimed at to treat the main cause of the pulmonary edema. Let's treat that. Okay. To remember, you can remember POND as pneumonia. So pneumonia is P